A very good evening to all of you, and we have come to the last session of this wonderful educational forum, which is done regularly by Dr. Jyoti and his team, and I should congratulate him at this wonderful event where all the top people in diabetes and other specialities are joined together to give us more education. Thank you very much, and we go on with the topic. We have a common topic of heart failure and anemia to be given by the talk is going to be given by Dr. Krishnakumar, and he is the professor in cardiology of Government Medical College, Cochin, Kerala. He is a senior interventional cardiologist and is at present the secretary of National Familial Hypercholesterolemia Research Foundation, and he has got a landmark study in genetics in familial hypercholesterolemia in southern part of India, and he has got some newer invention and finding out new mutations, and he is a reviewer of many journals in cardiology and has got a lot of papers to his credit, and I invite Dr. Krishnakumar to deliver his talk.
Good evening, sir. Good evening, sir. Respected chairpersons and distinguished members of the panel and the august members of the audience. First of all, without wasting time, I would like to delve deep into the subject of the heart failure and anemia. Matthew Thomas sir being a hematologist, and he can delve into the normal iron kinetics, iron metabolism, and anemia in cancer, anemia and whatnot, all the inflammatory conditions and all. But my topic is restricted to the anemia that is found in heart failure. So, according to the epidemiology, this is a Western epidemiology. If you are taking heart failure there are acute heart failure is there when a patient with post-MI or a dilated cardiomyopathy patient presenting with an acute heart failure. Then there is a chronic, the so-called stable heart failure is there. So there are so many types of heart failure: chronic heart failure, acute heart failure. So in these type of heart failure, in the chronic heart failure, it is around 50 to 60% or 40 to 60% of the chronic heart failure is having a prevalence of anemia. So heart failure is having a lot of associated comorbidities, but recent papers are highlighting the importance of anemia should be considered as an important comorbidity and it should be treated. That is what the focus of the topic is. And even in the acute heart failure, there is around 50 to 60% prevalence. These are all Western statistics, but there is a paper from Calicut that is also shows in Kerala the prevalence of heart failure is much more than that. 60 to 70 to 80% in acute heart failure, and 50 to 60 or 50 to 70% in chronic heart failure, there is prevalence of anemia. So the gist of the matter is the thing is that the prevalence of anemia is very far common in heart failure, and it should be treated. So, as far as the total iron metabolism is concerned, the cartoon or this cartoon shows that the total body iron is around 3 to 4 grams. You can see the right side of the liver, depicting the liver and the macrophage. Liver and macrophage is the storage of the iron pool. That is around 1000 milligram plus around 600 milligram in the macrophages or the reticuloendothelial system or the macrophage. And the functional pool is there belonging to heart, skeletal muscle, other tissues, and erythroid and non-erythroid. Non-erythroid means you are giving the myocardium, skeletal muscle, and other tissues. In the erythroid, it is bone marrow. So it is roughly around 400 to erythroid, and non-erythroid, it is around 700, around 2500 milligram of iron in the functional pool and 1800 milligram in the storage pool. Dietary intake is around 15 to 25 milligram per day, means around 1 to 2 milligram per day is absorbed in the duodenum and the proximal jejunum. And the losses are 1 to 2 milligram. These are the normal iron metabolism or iron kinetics in the body. So why there is, in the heart failure, there is anemia? So heart failure heart failure we can say, in a way it is a syndrome of neurohormonal activation or a chronic inflammatory disease you can call. So why there is anemia? You can see that in this cartoon, in the left hand, the major symptom of heart failure, especially the advanced heart failure, is cachexia or extreme fatigue. So cachexia, why cachexia is there? Because of the inflammatory cytokines are being produced. Among the inflammatory cytokines, one of the major inflammatory cytokines is IL-6, interleukin 6, along with interferon alpha, interferon tumor necrosis factor alpha. So these produces a chronic inflammatory state, and in the liver, because in the storage form, the absorption or the liver exchanges iron into the transferrin through the transferrin protein into the tissues. So this is being blocked by a protein called hepcidin. So the hepcidin production is activated by chronic inflammatory states. So in the cachexia state of the in the chronic inflammatory state of the heart failure, this hepcidin is being increased, and the hepcidin decreases the ferroportin or there's a ferroportin protein is there that increases the absorption of iron from the dietary sources in the jejunum and duodenum, proximal jejunum and duodenum, and to the release of iron into the transferrin pool from the liver, and there is this ferroportin molecule is there. So this protein is being inhibited by increased levels of hepcidin in heart failure. So there is an increased iron retention in macrophages and hepatocytes, decreased iron absorption, resulting in decreased iron availability in erythroid progenitors, causes functional deficiency. And in the renal changes, decreased renal blood flow is there, decreased peritubular PO2 is there. So this causes also increased erythropoiesis, and there is anemia is there. Then there is anorexia, malabsorption, bleeding, absolute iron deficiency is there, fluid retention is there causing hemodilution. These are the multiple causes of anemia associated with the heart failure. So I have already detailed everything. Why do patients with heart failure develop iron deficiency? It's the same thing. Hemodilution, poor diet or impaired absorption, drugs, antiplatelets, anticoagulants, then neurohormonal activation, inflammatory immune activations. There are so many factors. So what are the detrimental effects of iron deficiency? I have already told you there are erythropoietic and extra erythropoietic effects. Iron deficiency causes decreased hemoglobin, decreased RBC, decreased oxygen delivery, and decreased VO2 peak. And decreased myoglobin causes decreased exercise tolerance, decreased aerobic enzymes, decreased oxidative phosphorylase, tricarbonic TCA cycle, respiratory chain. So decreased oxygen utilization is there. So that results in fatigue, dyspnea, and cachexia, all those things. So decreased myocardial iron content is there, causing decreased myocardial or sarcomere disaffection, causing decreased LV function. So these iron deficiency anemia causes what? So it consistently has an independent predictor of hospitalization, worse symptomatic limitation. So NYHA class and quality of life. So quality of life is being impaired, and increased hospitalization and decreased functional capacity assessed by the 6-minute walk test and peak oxygen consumption. So all these will result in the 2016, for the first time 2016, European Society of Cardiology has said, so for the diagnosis and treatment of acute and chronic heart failure, you should include ferritin, transferrin saturation, total iron binding capacity, hemoglobin, and WBC. Rest of the things I am not considering just because of the topic is on heart failure and anemia. And in the 2022 American College of Cardiology HFSA, a focused update also says that serum iron, serum ferritin, and transferrin saturation should be the ways to diagnose the anemia associated with heart failure. So we have covered the epidemiology. We have covered why there is heart failure and anemia in heart failure. And we are coming on to the treatment part. Diagnosis also we have just covered. So the treatment part, why is there any effect on oral iron on the exercise capacity in patients with heart failure with reduced ejection fraction and iron deficiency? So whether IV iron is superior or whether we can use oral iron for the treatment of anemia associated with heart failure. That is what the study, so 2017 study, there is a study called Iron Out. So that study shows that oral iron repletion does not increase exercise capacity. One of the limitations of oral iron is, see, if you are giving oral iron, so that will cause daily 3 times or 2 times. After a single dose, that will cause an increase in hepcidin, especially in heart failure. So increased hepcidin causes further increase in functional iron deficiency. So the previous studies failed to understand this. The recent advances in the iron kinetics study, science into the iron kinetics and research shows that oral iron should be given daily, means alternate days, in order to suppress the production of hepcidin. So these results or these science was not available in those periods where the oral iron studies were done, that is 2017, 2018 and all. So those days oral iron was given in multiple doses or daily, not alternate days. So that resulted in the decreased utilization of efficacy of oral iron in the management of heart failure. Though this cartoon shows that oral iron repletion does not increase exercise capacity. So what are they? So that finishes the efficacy of oral iron in the management of anemia associated with heart failure. At present, there is no role for the oral iron. So what are the intravenous iron formulations available at present? So there is iron dextran is available, iron sucrose is available. Iron dextran has to have a test dose, and iron sucrose that is available in our part of Kerala or in India, it doesn't require a test dose. Maximum dose is 200 milligram, but FDA indication is only in CKD. And there is HF specific studies are observational and small RCTs. Then the 2 compounds, that is ferric carboxymaltose, that is FCM, and ferric derisomaltose, both of them are having indication in heart failure, but only ferric carboxymaltose is having multiple RCTs and evidence in heart failure with a mid-range ejection fraction, heart failure with a reduced ejection fraction, and acute heart failure also. The indication for acute heart failure has not come into the guidelines. So I will right now going into the different studies and meta-analysis, different studies on anemia in heart failure with the IV iron preparation called ferric carboxymaltose. So effects of ferric carboxymaltose on hospitalizations and mortality in congestive heart failure and iron deficiency anemia in individual patient data meta-analysis shows that you can see the black boxes favors onto the left side of the line of unity. So that shows that it favors the FCM or the ferric carboxymaltose. So that has resulted in the indication or of ESC 2016 heart failure guidelines. So it states that intravenous ferric carboxymaltose should be considered in symptomatic patients with heart failure with reduced ejection fraction and iron deficiency. Here iron deficiency is defined as serum ferritin less than 100 microgram per liter or ferritin between 100 to 299 microgram per liter and transferrin saturation less than 20% in order to alleviate heart failure symptoms and improve exercise capacity and quality of life. Then came the study affirms acute heart failure, that is ferric carboxymaltose in iron deficient patient with a heart failure with a reduced ejection fraction, that is less than 40% ejection fraction, and heart failure with a mid-range ejection fraction up to 40 to 49. So there also it shows total heart failure hospitalization and CV death is predominantly affected, and CV death doesn't have any effect. So that resulted in the 2021 heart failure guidelines. So there, intravenous iron supplementation with ferric carboxymaltose should be considered in heart failure with a reduced ejection fraction as well as heart failure with a mid-range ejection fraction. So what is the approved label for what is the dosage of ferric carboxymaltose? You can say that you can give 1000 milligram or it is 1000 milligram if it is if the hemoglobin is less than 10 gram per deciliter, or 1000 milligram followed by after 6 weeks there is a 500 milligram. You can see the dosage schedule. There's a FDA indicated thing is there. And now we are coming on to the different molecule called ferric derisomaltose. That is an Ironman trial design is there. And so that resulted in, so affirm HF and Ironman. So there is usage of IV iron. This is only in IV, this ferric carboxymaltose and ferric derisomaltose. These can be useful in heart failure with a reduced ejection fraction and heart failure with a mid-range ejection fraction. So the same thing, both of them, confirm HF, affirm AHF, heart FID, Ironman. So these 2 compounds are effective in this heart failure with a reduced heart failure and anemia. The same thing, different meta-analysis that is published in 2023. That has resulted in the current 2023 recommendations for the management of iron deficiency in patients with heart failure. Intravenous iron supplementation is recommended as a class 1 in symptomatic patients with heart failure with reduced ejection fraction and heart failure with a mid-range ejection fraction iron deficiency to alleviate heart failure symptoms and improve quality of life. And intravenous iron supplementation with ferric carboxymaltose or ferric derisomaltose should be considered in symptomatic patients with heart failure with reduced ejection fraction and heart failure with mid-range ejection fraction and iron deficiency to reduce the risk of heart failure hospitalization. So what is still to come? You can see the right end of the trial, the right end of the cartoon. There's a Infer RCT trial is there, where the only indication heart failure, the anemia is being diagnosed by TSAT less than 20%. So that is a post-MI. So right now, from the heart failure with the reduced ejection fraction, now the anemia of heart failure with the preserved ejection fraction and the post-MI anemia is being targeted by IV iron formulations. So right now there's a rethinking is that how to diagnose anemia in heart failure. Now the current thinking is that you don't need serum ferritin, only transferrin saturation is needed or serum iron. Transferrin saturation should be less than 20%. That is the only one criteria. Recent studies have stated that transferrin saturation is the only one thing to diagnose anemia in heart failure. That is, it should be less than 20%. You don't need serum ferritin because serum ferritin being an acute phase reactant, that will increase in inflammation and all. You don't. So it will overestimate or underestimate anemia. Same thing that what I have stated, TSAT versus ferritin. It shows that superiority of TSAT. So summarizing, iron deficiency is common in heart failure patients, affects quality of life, mortality and hospitalization. Diagnosed using serum ferritin and transferrin saturation concentrations, treatable with IV iron. In patient with heart failure with reduced ejection fraction, IV iron reduces hospitalization while improving exercise capacity. IV iron given to patients with HFrEF and iron deficiency improve quality of life, symptoms, functional capacity. For iron deficiency in heart failure patients, initiate therapy before hospital discharge, continue treatment post-hospitalizations. Summarizing and concluding, only IV, not oral preparations, replete iron stores, average of 1,000 to 2,000 milligram required with repeat dosing as needed, early and sustained impact on quality of life and functional status, multiple formulations shown to be unequivocally safe, benefits for clinical outcomes are proportional to baseline risk, recommend to screen, replete and repeat as needed. So, thanking you, I think.
Thank you very much, Dr. Krishnakumar, for that wonderful talk, because it is very important to know the preparation of IV iron, especially ferric carboxymaltose, which is freely available, and it has changed the treatment of iron deficiency a lot, and all the targets have come down. So even if you find a patient with a hemoglobin of 8 grams, 9 grams, and if you tell them the advantages of the oral iron, they will prefer oral iron than, they will prefer the ferric carboxymaltose to oral iron because of the very quick effect. And in heart failure, if there is a iron deficiency, the choice of treatment is definitely ferric carboxymaltose. And the other cause of anemia in heart failure, as he told, is anemia of inflammation. This is a new term which we previously called as anemia of chronic disease. Now the new name is anemia of inflammation, and he has told a wonderful pathogenesis where the body, there is any form of inflammation, the cytokines are increased and they hinder the production of red blood cells and reduce the erythropoietin producing anemia. And that will not be treated, that cannot be treated by iron, but there are no definite methods to treat that except treating the basic disease of cardiac failure, but large dose of erythropoietin may be helpful. So it's a wonderful talk, and you'll have to go home and think about IV iron for iron deficiency anemia, whether it's cardiac failure, whether it is nutritional, whether it is anything. It has no side effects. The side effect data, as we think of fear of hypersensitivity reaction is 0.0001. So this is the present status of the hypersensitivity. If they have a hypersensitivity or allergy, you will have to be careful. That is all. And I will ask Shaji for the discussion and the conclusion.
Thank you, Dr. Krishnakumar, for a wonderful presentation. You have covered the prevalence, the mechanism and the treatment of anemia in heart failure. Over to the audience for any questions.
Any questions?
If there are no questions, we'll wind up.
Yeah. What's your good name? Dear Ananda Krishnan, these are all very confusing things. TIBC, TSAT, serum ferritin, hemoglobin, serum iron. So right now, we need only two things. Serum iron or this thing, TSAT. TSAT is already means in our Kerala, all the laboratory TSAT is being done. If the TSAT is less than 20%, you should go for the treatment. And give treatment. Right now, the hell number of studies are with ferric carboxy maltose. That there are HFrEF, heart failure with mid-range ejection fraction, acute heart failure. You can give. So if the TSAT is less than 20%, go and treat it till the TSAT is improves. TSAT means it's a transferrin saturation. It reflects transferrin. So it is a balance between storage and the usage functional pool. So if it improves, if it is more than, or the serum, if you can do serum iron, if the serum iron is less than 13, you can go for the same thing. So confusing total iron binding capacity, confusing serum ferritin, it will create multiple doubts because whether if it is increased. So initially in 2016 or 2013, WHO has come up with the definition of anemia, HB less than 12 in females, HB less than 14 in males. Then comes the ESC and ESC, American College of Cardiology, that they will focus on ferritin 100 to 300. So that caused a lot of confusion. Because ferritin being an acute phase reactant, it increased dramatically. Even 700 ferritin means there is functional anemia is there. But we are not treating it according to the current ESC guidelines. But if you are putting the thrust is on TSAT less than 20%, everything is done. So TSAT less than 20% has got a direct correlation with death, absolute cardiovascular death. So if you are treating, the only indication is TSAT less than 20%, forget about all those things, all the other things. This is the latest research on heart failure, anemia in heart failure. So associated medication comorbidities, and you have raised a very valid point, and if there is any practical point regarding the usage of PPA, I will I can ask the opinion of Matthew Thomas sir. But the thing is that even the PPA, even in the larger trials, all these randomized controlled studies, they haven't observed a significant interaction with the drug and this thing. And the second thing is that I think Indians, all of them take tea along with their breakfast or the means snacks and all. That tea is also a significant cause of iron deficiency anemia in the Indian population. And this thing regarding the usage of PPA and all, is there anything to be highlighted, Matthew Thomas sir?
I think it leads to many other problems, including B12 deficiency, because B12 absorption is prevented when there is a PPI, and a lot of infections because the bacteria which is in the gut are usually killed by the hydrochloric acid. So if you just deplete the hydrochloric acid, the patient becomes more prone for infection. So I don't think iron has got anything to do with that, but vitamin C will increase the absorption. So in some cases we add only for an oral iron. Oral iron, the absorption is increased by vitamin C, and as he said rightly, tea and coffee will reduce the absorption. So PPI does not seem to have any role in the iron absorption.
Sir, you have raised a valid point, and the thing I wanted to tell is that right now there is a very good formulations of oral iron that is coming up. That is pre-packaged with vitamin C, vitamin B12 and all, increase absorption of anemia, to decrease the incidence of prevalence of anemia, so all those things. So this will be formulated in a new formulation that will be tested in the future trials. Sir, you wanted to make a...
Thank you, sir, for that wonderful presentation. Have you come across cases of IV allergic reaction to IV ions? So how to deal with that?
Yeah, that's a wonderful question. I think these trials, these landmark trials of FCM, that is ferricarboxy maltose, that's a Polish scientist is there, doctor is there, Jan Kowalska or somebody. So she rightly said in the recent meeting in the Heart Failure Association, in the European Heart Failure Association, just concluded 2 months back, she categorically stated that it can be given very safe in the OP. Means in your clinic, it can be given, there is no anaphylactic reaction. That is what she says in the conference. There is no anaphylactic reactions. Only anaphylactoid reactions are there that you can manage with antihistamines and all. But she categorically states that there is no history, there is no incidence of any evidence of anaphylactic reactions. Anaphylactoid reactions, nausea, giddiness, then dyspnea is there. Allergic reactions are not at all. Serious allergic reactions are not at all there. But there's, I think, Matthew Thomas sir has said.
I think I've already given you the statistics of allergic reaction or anaphylactic reaction is 0.00001. Large, many millions of patients have been tried. So only if they have an allergic history, like an asthma, you'll have to be a little careful. Otherwise, I've given thousands and thousands. Not even a single anaphylactic reaction.
And I haven't come across allergic reactions because while I was working in Trivandrum, my wife is a nephrologist. But there also they give, I think, I haven't heard of this thing, allergic reactions, anaphylactic reactions. Allergic reactions are there, itching or something like that. Anaphylactic reactions are not there, serious. Especially with ferricarboxy maltose.
Okay, thank you. With that, we will conclude today's session. Thank you so much.
Thank you, sir.
Thank you so much, chairs and speakers, for the wonderful session. With this, we have come to the end of today's session. All the sessions were interesting and informative. See you all again tomorrow with more informative fields. We shall begin tomorrow's session by sharp 8:30.